So today I'm going to be going through my grill, Cefazolin plus Ertapenem, a new salvage treatment for MSSA bacteremia. My content expert for this was Brian Buss, so thank you so much, Brian, for all your help with this presentation. So throughout this presentation, we'll have 4 different objectives. We'll be looking to compare the efficacy and safety of Cefazolin and the Anti-staphylococcal Penicillins in the treatment of MSSA bacteremia. We're going to define the inoculum effect. We're going to evaluate if ertapenem can overcome the inoculum effect, and then we're going to examine the efficacy of cefazolin plus ertapenem for MSSA bacteremia. So for the first part of this, we're going to be looking at the treatment of MSSA bacteremia. So what are the guideline recommended treatments for MSSA bacteremia? Traditionally, the first line treatment for MSSA bacteremia are beta-lactams. And of those beta-lactams, we first think of the anti-staphylococcal penicillins, which will be termed as ASPs throughout this presentation. Here we have nafcillin, oxacillin, and flucloxacillin as a couple options pending the institution's formulary. And then our second line treatment option, which we see quite often, is cefazolin, 2 grams IV, Q8 hours. So why are the anti-staphylococcal penicillins, or the ASPs, considered first line treatment for MSSA bacteremia? So in general, beta-lactams have shown to be superior to vancomycin for the treatment of MSSA bacteremia. But the ASPs specifically, they typically have better CNS penetration and are more often used for more severe infections. We're thinking things like abscesses, endocarditis, meningitis, more severe infections. The oxacillin and nafcillin specifically have a narrower coverage as compared to cefazolin as well. So if we're being good stewards, we're wanting to select antibiotics that have the narrowest coverage for what we're treating, so reducing unnecessary gram-negative exposure. And there's also the concern for cefazolin failure due to the inoculum effect or high burden of disease. So in general, how does cefazolin compare to the anti-staphylococcal penicillins for the treatment of MSSA bacteremia? So this systematic review and meta-analysis by Rendon et al. Compared cefazolin and the ASPs against each other. So they included 9 retrospective and 1 prospective trial, including 4,728 patients being treated for MSSA bacteremia. This patient population was variable in their disease severity, so this ranged from the general care population to the ICU population. There were 2,954 patients in the anti-staphylococcal penicillin group and 1,774 patients in the cefazolin group. Their endpoints were mortality, clinical cure, relapse, and withdrawal from adverse effects. And here we have the results from this study. So in regards to mortality, clinical cure, and withdrawal from adverse events, all of these endpoints were statistically significantly favoring cefazolin over the ASPs. So patients who were treated with cefazolin had less mortality, higher overall clinical cure, and less withdrawal from adverse events. So the conclusion that they came to from this meta-analysis was that cefazolin is not only safer, it's also more effective as compared to the ASPs in the treatment of MSSA bacteremia. Now, the limitations of the study, in general, lower quality trials and borderline high heterogeneity. And here we have the forest plot from this study looking at mortality. And as something I find interesting from this forest plot, it shows that of the pooled studies that they included, none of them really favored either cefazolin or the ASPs, but when combined, there's clearly cefazolin was more beneficial. And of note, I'll point out the high heterogeneity in the I-squared there too, of 51%. In this second recent systematic review of meta-analysis by Weiss et al., they included 14 non-randomized studies looking at cefazolin versus the ASPs in MSSA bacteremia. And they looked at 90-day all-cause mortality and then 30-day all-cause mortality, treatment failure, relapse, and nephrotoxicity. So adding in some of those safety endpoints as well. And here are the results for this study. So the 90-day all-cause mortality, nephrotoxicity, and 30-day all-cause mortality, the nephrotoxicity and the 30-day all-cause mortality were statistically significantly in favor of cefazolin over the ASPs. However, the 90-day all-cause mortality, there was no statistically significant difference. However, there was a trend in statistical significance. In regards to treatment failure or relapse, there was no statistical significance. So Cefazolin was considered to be at least equally effective, maybe superior within 30 days as compared to the ASPs. But it's also noted to be less nephrotoxic as compared to the ASPs as well. And here's the 90-day all-cause mortality forest plot. So again, we can see kind of across those studies that are included, no major favoritism of Cefazolin and no real difference between the two. And then looking at the nephrotoxicity, also clearly in favor of Cefazolin with very low heterogeneity amongst those studies. So in summary, when comparing the Cefazolin with the anti-staphylococcal penicillins, in general, Cefazolin had a lower mortality rate as compared to the ASPs, had overall higher clinical cure. There were less adverse events with Cefazolin. In general, it has a more favorable dosing schedule, Q8 hours versus the Q4 hours we typically see with the ASPs, and then lower cost. So in general, in a heterogeneous population of patients from kind of Gen Pop through ICU status, it seems that Cefazolin is a great choice for MSSA bacteremia. But how do disease states that may have a higher burden of infection affect Cefazolin treatment outcomes? So Weiss et al. Actually included this in a sub-analysis in their meta-analysis. So they looked at patients who may have disease states that are at risk for higher pathogen inoculum. So they included both endocarditis and abscesses. So there were 652 patients included for endocarditis and 273 patients for abscesses. And they looked at both 90 and 30-day all-cause mortality. As we can see across these results, there are no statistical significant difference between either endocarditis or abscesses with ASPs or Cefazolin. So in patients with higher risk disease, there seems to be no difference in treating with Cefazolin versus the ASPs. And here we have the four forest plots. On the left, we have endocarditis. So on the top, we have 90-day all-cause mortality. They included 3 studies for the 90-day all-cause mortality. And there's clearly no difference here. In the 30-day all-cause mortality across endocarditis and abscesses on the right, they also included 6 studies for this, which also showed no difference between the two. So no difference between endocarditis or abscesses for Cefazolin or ASPs. And as I mentioned in summary, for disease states of higher risk of inoculum, no real difference between ASPs and Cefazolin. So the data continues to show that Cefazolin seems to be most beneficial here. Why aren't we using Cefazolin over the ASPs in the treatment of MSSA bacteremia? So ultimately, what's the catch here? So this study comes from Korea, and Lee et al. Looked at Cefazolin versus Nafcillin in MSSA bacteremia. And this was a prospective cohort study across 10 different hospitals. And looked at patients who, as mentioned, received either Cefazolin or Nafcillin as definitive antibiotics for their treatment of MSSA bacteremia. They defined the minimum inhibitory concentrations as a standard inoculum of 10 to the 5th CFU and a high inoculum of 10 to the 7th CFU. And the Cefazolin inoculum effect was defined as an MIC increase to greater than or equal to 16 micrograms per mil when tested at high inoculum, so that 10 to the 7th CFU. Their endpoints were treatment failure, whether that be premature discontinuation from the antibiotic, switching because of clinical failure, all-cause mortality with 1 month, or reoccurrence. And here are those results. So in regards to overall treatment failure, premature discontinuation of antibiotics, and mortality within 3 months, all of these endpoints favored Cefazolin, which is not surprising after the previous systematic reviews of the meta-analysis we saw. Outcomes were typically better with Cefazolin as compared to the ASPs. However, 22% or 24 out of the 110 MSSA isolates that they were able to collect from this study showed the inoculum effect, or CzIE, which you will see throughout this presentation as well. And that had a significant impact on the failure rate and mortality of the Cefazolin group. And then of note, the 30-day all-cause mortality, antibiotic change because of clinical failure or recurrence, they had no statistically significant difference between the two. So their conclusion was that Cefazolin may be recommended as an adequate or better tolerated treatment for MSSA bacteremia, however, in the absence of the Cefazolin inoculum effect. So they dove pretty deep into the inoculum effect and how it affected outcomes. So as mentioned, the number of isolates that they were able to obtain was 110. They had 58 in the cefazolin group and 52 in the nafcillin group, and 24 out of those 110 showed the inoculum effect, about 22%. So in regards to the cefazolin group itself, so just that 58 isolate group from cefazolin, there were 13 isolates that were positive for the inoculum effect. And they individually looked at treatment failure rate, switching of antibiotics because of clinical failure, and rate of 1-month mortality, all of which were statistically significantly worse for patients who had an isolate that was positive for the inoculum effect. So patients who had a positive MSSA isolate with the inoculum effect had worse treatment failure, higher rate of switching of antibiotics, and greater mortality at 1 month. However, when pooling those results together, or pooling the isolates together between nafcillin and oxacillin, there was no difference between treatment failure. So ultimately, there's no treatment, there's not a significant difference between positive rates and negative rates of inoculum effect groups in regards to treatment outcomes. However, specifically for cefazolin, the inoculum effect was associated with treatment failure. So in summary, the anti-staphylococcal penicillins and cefazolin, they're two of the most common treatments for MSSA bacteremia, and with typically cefazolin falling as second line. In the treatment of MSSA bacteremia, what we saw in both high risk or high burden and low burden of disease, cefazolin really showed non-inferiority with lower side effects as compared to the ASPs. And then treatment failure caused by the inoculum effect, it may be a clinical concern when treating with cefazolin. This creates a whole new list of questions. What is the inoculum effect? When is the inoculum effect clinically relevant? And then what are our treatment options if cefazolin fails? And this leads us into our first clinical question. So historically, what's the main concern when using cefazolin in the treatment of MSSA bacteremia? Is it A, no coverage for MSSA, B, high risk for nephrotoxicity, C, concern for treatment failure due to the inoculum effect, or D, all of the above?
Not a lot of responses yet, Jake, but I say C.
C, it's a good guess.
Okay, yep, we got another C.
All right, perfect. This is a softball question to start. So yes, treatment failure due to the inoculum effect is the correct answer. So this will lead us on into part 2, looking at the inoculum effect. So what is the inoculum effect? So the inoculum effect is a phenomenon in some MSSA isolates that harbor the staphylococcal beta-lactamase enzyme, so BLA-Z, as you'll see it throughout. It results in cefazolin MICs to increase in proportion to the number of bacteria within the inoculum. So we have our standard inoculum, which we saw earlier in one of those previous studies, is 10 to the 5th CFU. That's a pretty common standard. And then the high inoculum is 10 to the 7th CFU, which is also the standard for high inoculum. So basically, as that inoculum increases to 10 to the 7th, the MICs for cefazolin also increase. And that's defined as an MIC increase of at least 16 micrograms per mil at the high inoculum and 8 micrograms per mil at the standard inoculum. Also to mention, the inoculum effect is not specific to cefazolin. It can occur with any beta-lactam, but is most commonly associated with cefazolin. So next we're going to move into the mechanism of action. Now I'll preface this slide by saying there isn't a clear agreed upon mechanism of action for the inoculum effect. This is a hypothesized mechanism of action that I'll be presenting the mechanism that's most agreed upon among the literature, but take that with a grain of salt. So basically the mechanism of action is hydrolysis of cefazolin by the BLA-Z beta-lactamases. There are 4 different BLA-Z beta-lactamases. There's the A, B, C, and D. The hydrolysis or the inoculum effect is seen most commonly in types A and C beta-lactamases. So at those high inoculum of 10 to the 7th, MSSA basically it's able to overcome the effect of cefazolin, the killing effect of cefazolin, and the BLA-Z hydrolysis basically overcome that killing effect and is able to deactivate the cefazolin. So on the right here, I have an image kind of walking through. This is with penicillin, but I think it still gets the point across. So on the bottom left, we have penicillin as the active antibiotic binding to BLA-R1, which causes a cascade of downstream effects, leading to BLA-Z expression, which is in the top left in that blue box. And when BLA-Z is expressed, the bacteria starts producing those beta-lactamase enzymes, which are released into the extracellular space and are eventually lead to the deactivation of the antibiotic. So a pretty straightforward mechanism, but ultimately it results in an MIC increase for cefazolin of up to 16 micrograms per mil. So what's the clinical relevance of the inoculum effect? As we saw with some of the previous studies, it does have a possible treatment failure result. It's especially a concern for those deep-seated MSSA infections and also correlates with severity and mortality of disease. So those disease states that we're kind of thinking about, those that are at risk for high inoculum are things like endocarditis, osteomyelitis, abscesses, pneumonia, areas that are difficult to get penetration with antibiotics and to really treat. So what's the prevalence look like for the inoculum effect across the country? So the American Society of Microbiology actually recently came out with a paper looking at the prevalence of the inoculum effect across North America. They looked at 7 different microbiologic laboratories across America, including one from Canada that you can see here on the map on the right. They ended up collecting 305 MSSA blood isolates collectively from these laboratories. So on table 1 here, we have the results from their collection. So on the left, we have the study site. We have the number of positive isolates. And then in the middle, we have the total number of isolates tested. And on the right, we have the positive isolates. So there were 57 total positive isolates. And I find it interesting, there was no real site that kind of monopolized the number of positive isolates. It was all kind of evenly distributed, with Texas being the odd one out with no positive isolates, with the percentage of positive isolates being on the right. And the interesting thing is it fell to about 18-19%. And if we looked at the last meta-analysis, or one of the previous meta-analysis out of Korea, it also showed that about 22% were positive. So it seems like around 20% tends to be kind of that sweet spot for positive MSSA isolates for the inoculum effect. But ultimately, there was no difference, no statistically significant difference as to where the isolates come from across America. And then in table 2, they listed out the standard inoculum and the high inoculum for both the inoculum effect positive and negative groups. So on the left here, we have those MICs listed. And then in the center, we have the positive group, the inoculum effect positive group, and then the negative group on the right. So I specifically want to draw your attention to the high inoculum sections bolded in red. If we can see for the high inoculum, for the inoculum effect positive group, there's not a single MIC less than 16. All of them are 16, 32, or greater than 32, versus the inoculum effect negative group, which did not have a single MIC greater than 8. So there's a clear difference in the MICs versus the positive and negative group across the isolates. If we look at the modal MIC at the bottom, the modal MIC for the high inoculum group was 32 versus the negative group, which was 1. So huge differences here in those MICs, drastically different for all these isolates. So some of you members of the audience might have made an astute observation and thought, hey, why don't we just test for this? Why don't we just look at this in the micro lab? That way we can make sure that the patients get put on the correct therapy right away and we don't have to worry about it. Unfortunately, there is no gold standard test to identify the inoculum effect. So broth dilution is really the only way we can identify the inoculum effect, and it has to be done on those MSSA isolates both at 10 to the 5th CFU and 10 to the 7th CFU. It also needs some expertise in the lab to do that, and with the amount of MSSA isolates that go through the lab, it's just not feasible to do. On the right here, I have an example of what that broth microdilution looks like, just for understanding. But basically, those isolates need to be obtained and they need to be grown, and then they need to be placed in the dilution series of antibiotic. And then this needs to be done at both 5 times 10 to the 5th CFU and 5 times 10 to the 7th CFU. So basically needs to be doubled and confirmed with the incubation time. And then after it's incubated, the vial with the clear no growth is the MIC. So as we can see from this example, there's no growth in the 64 vial. So the MIC for this example would be 64. BLAZ targeting has also been something, an area of interest as to targeting whether or not the isolate has or shows the inoculum effect. However, it's not a realistic target because 90% of staph species have the BLAZ gene. As mentioned, there were 4 different A, B, C, and D, so it's really not a feasible target. And ultimately, we don't really know what we're targeting or what really causes it because we don't have a clear mechanism of action. All right, so what are the clinical implications of the inoculum effect? So this study by Miller et al. Looked at how the cefazolin inoculum effect was associated with mortality in Staph aureus bacteremia. So this study was a prospective cohort study out of Argentina in 3 different hospitals in patients with Staph aureus bacteremia who were treated with cephalosporins as first line. So all the blood isolates were collected directly from the patients with MSSA bacteremia. The MICs are our typical 10 to the 5th CFU for the standard inoculum and 10 to the 7th for the high inoculum, as well as our typical cefazolin inoculum effect definition of an MIC increase of greater than or equal to 16 at the high inoculum. And their endpoint was 30-day mortality. And here are those results. So there were 77 patients and 89 MSSA isolates. 54.5% of those isolates were positive for the inoculum effect. In regards to their primary endpoint of the 30-day all-cause mortality, there was a statistically significant difference between patients who had the positive isolate and negative isolate. Outcomes were worse for those who had a positive inoculum effect isolate. They also they did multivariate analysis to control for confounders, and it was still positive, or still statistically significantly positive, worse outcomes for the positive group. They also found that 30-day all-cause mortality from a secondary source of bacteremia was also statistically significantly worse for patients who had inoculum effect positive isolates. There was, however, no statistically significant difference between observed age, clinical illness severity, place of acquisition, or presence of endocarditis. So their conclusion from this study was patients with MSSA bacteremia, where cephalosporins are first-line therapy, the inoculum effect is associated with an increase in 30-day mortality. Now, this study by Lee et al. Also looked at the clinical implications of cefazolin inoculum effect in MSSA bacteremia. Things across here will look very similar. It's a retrospective cohort study in patients treated with cefazolin. They defined the MSSA or the cefazolin MICs as an increase in 4 times. The MIC had high inoculum with a CzIE positive group of 5 times 10 to the 7th, and the CzIE negative group with 5 times 10 to the 7th, anything less than that value. So they included kind of that gap area of 5 times 10 to the 6th. And they looked at the cefazolin treatment group of 12 weeks, or treatment failure at 12 weeks, and MSSA bacteremia persistence. And here are those results. So 113 patients and 113 isolates, 57.5% were positive for the inoculum effect. And in regards to persistent bacteremia, there was a statistically significant difference between the positive and negative groups. So the positive groups had worse outcomes, more persistent as compared to patients with negative isolates. There was, however, no difference in treatment failure between the positive group and the negative group. But when they performed multivariate analysis, they found that patients who had underlying cardiovascular disease, pneumonia, osteoarticular infections, and endocarditis, those were statistically, there was significant risk factors for treatment failure when treated with a CzIE positive isolate. So their conclusion from this was that the inoculum effect, it might be associated with persistent bacteremia if cefazolin is used in high burden infections. However, the site of infection seems to be more important in regards to the clinical outcomes when the inoculum effect is present, which kind of goes along with what we were talking about earlier with those infections with higher inoculum risk tending to have worse outcomes when cefazolin's used. So in summary of the inoculum effect, there are hypotheses as to what causes the inoculum effect. However, there isn't a clear answer as to what actually causes it. There's no gold standard test to really treat or to really identify the inoculum effect or inoculum effect positive strains. Blasi was thought to be a target, but due to it being in greater than 90% of MSSA isolates, it's not a great option for targeting. And then studies kind of show variability in how clinically relevant the inoculum effect is. We saw sometimes in some of these studies that there was treatment failure with it, and then others there wasn't a statistically significant difference in treatment failure. However, maybe the site of infection may be more important in playing into the efficacy of treatment with the inoculum effect. So those high-risk infections like endocarditis, pneumonia, abscesses, and osteoarthritis. So when situations like that do occur, we have a high inoculum infection, and cefazolin really isn't treating it. What treatment options do we have? So this leads into my second clinical question. So the cefazolin inoculum effect is defined as cefazolin MIC increased to what level when MSSA is grown to 10 to the 7th CFU? So we have greater than or equal to 32, equal to 128, greater than or equal to 8, or greater than or equal to 16.
All right, Jake, we have some D's, couple
D's,
and a C.
D and a C. All right, the answer is D. So greater than or equal to 16 at that high inoculum. So nice job, everybody. So now we'll transition to cefazolin plus ertapenem in combination for MSSA bacteremia. So MSSA bacteremia salvage treatment, it's a very under-researched area of infectious disease just because of MRSA bacteremia being the focus and due to the high mortality risk with MRSA bacteremia. Like for example, there's an IDSA guideline for MRSA bacteremia. However, there's not one for MSSA bacteremia. I will mention that there is currently one in the works right now though. But this leads into the new synergistic combination beta-lactam of cefazolin and ertapenem. I have those two dosing listed here, 2 grams every 8 hours and ertapenem 1 gram every 24 hours as synergy dosing for salvage or refractory MSSA bacteremia. Now you might be wondering, well, it's kind of odd. It seems odd. Why are we doing 2 beta-lactams here? However, ertapenem and cefazolin, they actually have very synergistic mechanisms of action. Both of them target the PBP or penicillin binding protein proclivities that are on the cell wall that are essential for cell wall synthesis on the staph. So cefazolin binds to the PBP2 is a very high affinity for it. And then the carbapenem class has a high affinity for the PBP1. So basically we have a PBP2 and a PBP1 targeted antibiotic that are synergistic together that increases or enhances the killing of the bacteria. So how does cefazolin ertapenem work in vitro versus in practice? And we're especially thinking about those high inoculum risk infections like endocarditis, pneumonia, abscesses, and such. So recently, this paper came out by Gilberti et al., which included our own Warren Rose at the School of Pharmacy. This study is kind of a two-part study that looked at the MSSA, the in vitro analysis of the MSSA bloodstream isolates that were pulled from the retrospective side of this study for the patients. There was about, I think, 10 to 15 patients in a retrospective study that were included from two different Sharp hospitals out of California. They were patients with MSSA endocarditis, and they were either treated with monotherapy or ertapenem plus cefazolin. So that was kind of the first part. And then the blood isolates that were pulled from those patients, further analysis, more in vitro analysis and assays were performed based on those isolates. So those in vitro methods are in vitro assays that they performed were susceptibility assays. They did an endocarditis biofilm model, a minimum biofilm eradication concentration, or MBEC. You'll see that term quite a bit throughout this paper. And then antibiotic checkerboard assay. So they were able to obtain 10 clinical MSSA blood isolates from those patients from the first part of this study. And the purpose of this was really to look at the outcomes of MSSA endocarditis in patients treated with ertapenem plus cefazolin, and then to evaluate that MBEC or minimum biofilm eradication concentration, which is the concentration of antibiotic that can destroy a biofilm, of ertapenem plus cefazolin, and then comparing that with our more first-line ASPs lines of therapy. So in regards to the clinical cases or the clinical case side of things that they looked at, there were 5 patients within the ertapenem and cefazolin group that were treated with that, and then there were 12 patients who were treated with the standard of care, and that was monotherapy, either nafcillin or cefazolin. So the median day of antibiotic range prior to therapy was 6 days, but then the median duration of their bacteremia after the switch, it was a single day for ertapenem and cefazolin, so rapid clearing of the bacteremia. And then as compared to the standard of care, which was 4 days. So that was clearly statistically significant. And on the right here, we have a graph of what those days of bacteremia looked like. And the standard of therapy is kind of all over the board here as to how many days of bacteremia they continued to have versus cefazolin and ertapenem, which had clearly a quick turnaround for clearing that bacteremia. Now, next we're going to move into the in vitro side of the study. Now, there's going to be a lot of methods kind of working through here, but it's in order to give you a good understanding of the background of what the results mean when we get there. So I'll briefly go through these, kind of give a description of each one of these assays and what they are doing, and what they're looking for, and the purpose. So they started with an in vitro susceptibility assay, and they had MSSA isolates for both ertapenem, or they identified the susceptibilities of ertapenem, cefazolin, and nafcillin under both conditions, the standard inoculum and the high inoculum, so our typical 10 to the 5th and our 10 to the 7th. They then did an MBC, or a minimum bactericidal concentration, for each of those antibiotics as well. So if you remember previously, we looked at the MIC and kind of how that's formed. The MBC assay is similar, but it just takes things an extra step. So if you could recall, in the MIC assay, the MIC was the vial that showed no growth. However, they plate those vials further, and the vial that shows 0 growth on the plate is actually the MBC. So on the right here, I have an image of what that would look like. So in this example, 4 micrograms per mil would be the MBC of this antibiotic. And below, I have one of the plates is what the plates look like as we kind of go through the biofilm model that they use, just for your reference. All right, and here's what those MBC values look like. So on the left, we have the isolates. There's those 10 different isolates. There's also ertapenem, cefazolin, and nafcillin at the top, and then they're split into the standard versus the high inoculum. So I'll specifically draw your eye to the high inoculum groups for all ertapenem, cefazolin, and nafcillin. And we can see between the standard inoculum and the high inoculum, there's drastic differences between the two. So at high inoculum, very elevated MBC levels for each of those individual antibiotics, especially ertapenem. Now next, I'm going to shift into the biofilm model assay. Now this is the assay that they used to create their biofilms that they did their in vitro testing on. So I'll briefly go through this. On the right here, I just have an image that kind of walks you through my description as we go through, just for a better visualization of what it actually looks like. So as I mentioned earlier, the MBEC is the minimum biofilm eradicating concentration. So that's the concentration in order to destroy a biofilm. So basically they took one of those trays and they filled the wells with a medium that included human plasma of healthy donors, and they inoculated it at 1 × 10⁶ CFU for each isolate, and they incubated that for 24 hours. They then stained those biofilms with crystal violet, and that crystal violet incorporates itself within the biofilm, and it really shows the density of the biofilm. So after they stain it, they're then able to run it through a microtiter plate reader, which is in the bottom right, and that shines a light through reading that crystal violet, giving a reading, and being able to quantify how dense or how formed that biofilm biomass actually is. So that was kind of the basis for creating those biofilms, leading into the MBEC assays. So the minimum biofilm eradication concentration of the individual antibiotics, they took those created biofilms, they let them establish them for 24 hours. They then transferred them to plates containing ertapenem, cefazolin, and nafcillin individually. They washed out any residual antibiotic, put them on new a new base with new media, and they let it incubate for 24 hours. And the MBEC or minimum biofilm eradicating concentration values were determined as the lowest test concentration that resulted in growth in the well. Minimum eradicating concentration values were determined as the lowest test concentration that resulted in no growth in the well. So on this page here, we have the combinations. So on the right, we have the synergistic checkerboard assay, which is an example, kind of a visualization of what this looks like. It gives a better understanding, I think. So this included both a combination ertapenem plus cefazolin, ertapenem plus nafcillin, and nafcillin plus cefazolin. So basically, they took different dilutions of the antibiotics, and they checkerboarded them across this assay. So if you can see across the top has compound A with different concentrations going across the top, and then compound B with different concentrations going across A through H. So basically, they have different concentrations in each cell within the biofilms. So after they did that, they incubated that, and then they plated that on new media and incubated that for 24 hours. So the combination of the MBC values, were also determined as the lowest test concentration that resulted in no growth in the well. So I'll go through what the synergy and the differences in the FIC on the next slide, but I think that picture gives a nice representation of kind of what that looks like. So in regards to synergy, they calculated synergy by looking at the fractional inhibitory concentration FIC index value, which is the FIC of antibiotic 1 plus the FIC of antibiotic 2. And what that FIC is it's the minimum biofilm eradicating concentration of the combination antibiotic divided by the antibiotic 1 alone. So for example, if we have ertapenem and cefazolin, if we're looking at ertapenem's FIC, it's going to be the combination of ertapenem plus cefazolin divided by ertapenem itself. So the synergy, I have those values listed here. So we have synergy through antagonistic. So synergy meaning that they're working together to destroy the biofilm, or antagonistic meaning they're not working together at all. So the specific value that we're looking for is the 0.5. And here we have the results from those assays. So we have 10 different isolates on the left, and then we have the individual antibiotics, ertapenem through nafcillin. And we can see that those MBECs are quite high, mostly the 2048. And then in combination, we can see that individually ertapenem and cefazolin both greatly decreased. And the FIC is generally across the ertapenem plus cefazolin is less than 0.5. So it's clear here that there is synergy between ertapenem and cefazolin. Now looking at ertapenem nafcillin and cefazolin nafcillin, they also have downtrends in their MBECs and their FICs, but they tend to be more additive and different, with the synergy mostly being between ertapenem and cefazolin. Now, this graph shows this in another view. So we have the ertapenem serum concentration of the antibiotic. So as we can see here, this is a typical dosing curve of the serum concentration of ertapenem. And then on the side here, we have overlaid the MBEC of ertapenem along with the combination, including the MBC and the MIC. So if we look at the MBEC of ertapenem, it's greater than 2048 micrograms per mil, which is not achievable with our standard dosing. However, if we look down at the MBEC in combination of cefazolin, adding cefazolin in, it greatly reduced the MBEC into levels that we can dose at. So if we see it crosses at about 7 hours, which is a doable with our dosing scheme. And then also we have cefazolin's overlay here with its serum dosing concentrations. We can clearly see here too that adding ertapenem to cefazolin brings down the MBEC down to 32, also possible to dose within about that 7 to 8 hour range in order to meet that minimum biofilm eradicating concentration. However, when we look at nafcillin, It doesn't matter if we add cefazolin or ertapenem, we still can't reach levels that are possible to dose at with our typical dosing schemes. So to kind of wrap things out here, round things out, I wanted to look at some final retrospective case studies using cefazolin and ertapenem. So this study looked at 11 retrospective individual case studies that look at the use of cefazolin and ertapenem for MSSA bacteremia. And here are the results for these case studies. So there are 11 cases. 6 of those cases were infective endocarditis, and they also included osteomyelitis, abscesses, pneumonia, and meningitis. So these are some serious infections that are at high risk for treatment failure and the inoculum effect. The median duration of the bacteremia while on antibiotics prior to the switch to ertapenem plus cefazolin was 6 days. The 9 out of those 11 cases, they collected daily blood cultures, and of the 8 of those 9 cases, the bacteremia was cleared in 24 hours. So rapid clearing despite having some serious infections that have failed treatment for the last few days. All patients survived to hospital discharge. All MSSA bacteremias were successfully cleared using the combination, and 3 of the 6 isolates that they were able to collect showed the cefazolin inoculum effect. So it's clear here that ertapenem plus cefazolin, they can rapidly clear the bacteremia, and the cefazolin inoculum effect really didn't affect anything. Something interesting of note, though, is that one of the patients who was discharged off ertapenem and just on cefazolin monotherapy, and they eventually ended up having reoccurrence of their bacteremia and ended up being put back on ertapenem in order to clear their bacteremia. So it seems like the combination needs to stick around in order to have successful therapy. So in summary, for cefazolin plus ertapenem for salvage MSSA bacteremia. So in biofilm models, high inoculum MICs, the addition of ertapenem and cefazolin reduced the elevated MICs to physiologically achievable levels with our standard dosing, as we saw with those graphs. And then in patients with refractory or persistent MSSA bacteremia, the addition of ertapenem to cefazolin resulted in rapid clearing of the bloodstream despite some of those serious high inoculum infections. So where might ertapenem and cefazolin be a great option? So I think it's going to be a really great option for areas of high inoculum infections where we can't achieve source control or the infected material cannot be removed. So things like catheter infections, hardware infections, abscesses, or vegetations like endocarditis. And this leads into my final clinical question. What is the mechanistic rationale behind pairing ertapenem and cefazolin for MSSA bacteremia? Is it increased targeting of BLAZ, types in MSSA genome, prolonged MSSA bacteriostatic duration greater than 48 hours, increased MSSA heteroresistance at high inoculums, or complementary PBP1 and PBP2 binding affinity?
Have some D's, Jake.
Perfect. Yes, the correct answer is D, those PBP1 and PBP2 binding affinities. All right, so in conclusion, cefazolin is an effective alternative agent for the treatment of MSSA bacteremia in comparison with the ASPs. The inoculum effect had substantially increased those MICs in clinical models that we saw. The modeling shows that adding ertapenem to cefazolin, it reduced those elevated MICs to physiologically achievable levels at standard dosing. And then in clinical models, ertapenem plus cefazolin rapidly cleared refractory and persistent MSSA bacteremia. And with that, I will answer whatever questions people have.